Hello and welcome back to the Biochemistry for Health Sciences channel. In the last several videos, we discussed the biochemistry of calcium as well as hypercalcemia. In today's video, we'll discuss the biochemistry of hypocalcemia. Recall that the reference range for serum calcium is about 8.5 to about 10 milligrams per deciliter. That comes out to be about 2 to 2.5 millimolar. Hypocalcemia, the total calcium is less than 8 milligrams per deciliter. So that's about less than 1.9 millimolar. How common is hypocalcemia? In hospital patients, it's estimated that about 20% have hypocalcemia, and that number increases to 85% in the intensive care unit. The most common causes of hypocalcemia include vitamin D deficiency, hypoparathyroidism. This may happen because of accidental damage or accidental removal of the parathyroid glands during thyroid or parathyroid surgery. There could be idiopathic reasons, unknown reasons for hypoparathyroidism, and hypoparathyroidism could be due to autoimmune disease. And another common reason for hypocalcemia is kidney disease. So we shall look at these three. There are other causes of hypocalcemia that includes magnesium deficiency. Magnesium affects PTH as well as vitamin D functions. Acute pancreatitis can cause hypocalcemia because the calcium can complex with fatty acids that are released in pancreatitis, inflammation of the pancreas, thereby forming these complexes that take away the calcium and reduce serum calcium levels. Medications can cause hypocalcemia. There are chelators such as EDTA and gadolinium contrast agents that can also bind calcium and lead to low serum calcium. Recall from video 9.6, we discussed vitamin D effects. The active form of vitamin D is calcitriol. You can see overall calcitriol increases serum calcium by increasing absorption from the GI tract, by increasing demineralization of bone, and by increasing reabsorption from the kidneys. So all of these effects is to increase serum calcium. So clearly, if there is, for whatever reason, there is a deficiency in vitamin D, that is going to lead to a reduced level of serum calcium, what we term as hypocalcemia. In video 9.7, we discussed the effects of PTH. So PTH increases calcium reabsorption from the kidneys. PTH increases bone resorption. PTH increases calcitriol production in the kidneys by activating 1-alpha hydroxylase enzyme. So clearly, if there is decreased PTH, what we call hypoparathyroidism, then we are going to get excessive loss of calcium from the kidneys. We're going to get decreased bone resorption, and there's going to be decreased calcitriol production in the kidneys. And that decreased calcitriol production means there will be decreased vitamin D, and that will decrease the intestinal absorption of calcium, and all of these will lead to hypocalcemia. So hypoparathyroidism is a very common reason for or cause for hypocalcemia. Now, another reason for hypocalcemia is kidney disease. So if the kidneys are not working, then they won't be able to convert vitamin D into this active form, calcitriol, and with the low levels of calcitriol, we are going to end up with hypocalcemia. Now, impaired kidney function will mean that it will be unable to remove excess phosphate. So the serum phosphate levels increase, and remember in the earlier video, phosphate can combine with calcium to form insoluble calcium phosphate deposits, and these deposits end up in tissues and bones, and thereby removing calcium from the serum, leading to hypocalcemia. Now, what are the symptoms of hypocalcemia? Mild hypocalcemia have no symptoms unless there's a very rapid fall of calcium, such as the removal of parathyroid adenoma. Then we can see symptoms of hypocalcemia. In severe hypocalcemia, where the calcium concentrations is less than 1.9 millimolar, that's about less than 7.6 milligrams per deciliter, we do see symptoms of hypocalcemia. Now, the major symptoms of hypocalcemia include neurological, especially affecting the central nervous system, and that includes symptoms such as seizures, confusion, psychological changes, and then we have the neuromuscular symptoms, and that includes things like muscle twitching, spasms, tingling, numbness, carpal pedal spasm, that is involuntary painful contractions of muscles in the hands, the carpal part, or feet, the pedal part, and this may cause sharp flexing of wrists and ankles. In severe cases, there could be even tetany. Now, some of these signs and symptoms are observed only with provocation. For example, the Shostak sign, in this case, about 70% of cases with hypocalcemia, and in about 10% normal people, we see a twitching of facial muscles when the facial nerve is provocated, is tapped. A more specific sign is torso sign, which is seen in about 94% of cases with hypocalcemia, and only in about 1% normal people. So in torso sign, the patient will show spasm of the hand when the blood pressure cuff is inflated, and this inflation of the blood pressure cuff causes mild hypoxia. So this mild hypoxia causes spasm of the hand that we call torso sign. This is a more specific sign compared to Shostak sign. Now, why do these neurological and neuromuscular symptoms occur? And this is because this severe hypocalcemia causes an increased neuron as well as neuromuscular excitability. That means the neurons will fire much more easily, and that means if the neurons fire easily, and that skeletal muscle will also contract much easier. So what's the biochemical basis for this increased neuron and neuromuscular excitability due to severe hypocalcemia? Recall from a previous video that calcium, serum calcium or extracellular calcium, binds calcium sensing receptors on neurons, and this binding leads to signaling pathways, and one of the effects of these signaling pathways is an inhibition of these transport proteins called sodium leak channels, NALCN. So inhibition of this NALCN will make the membrane potential more negative, and so the resting membrane potential in this case, for example, might be around -70. However, In hypocalcemia, the low concentration of calcium in the serum or extracellular fluid will decrease this calcium inhibition of NALCN. So the RMP now from -70 becomes even less negative, let's say -60. This means that it'll be easier for the cell now to reach threshold and cause an action potential. So hypocalcemia, by decreasing calcium inhibition of NALCN, leads to an increased probability of opening this NALCN. There'll be an easier reaching of threshold, and that will increase neuronal firing. And in case of muscles, this increased neuronal firing means there'll be increased neurotransmitter release during hypocalcemia, and there will be more stimulation of the acetylcholine receptors at the neuromuscular junction, and that will lead to increased muscle contraction. And this is why hypocalcemia causes these neurological symptoms as well as neuromuscular symptoms. So with this video, we end the series on calcium. In the next video, we'll start looking at another analyte, the next in the comprehensive metabolic panel that we have been discussing, and we'll now look at this cation called sodium. So until the next video, once again, thank you very much for watching and supporting this channel. Have a wonderful, wonderful day, and we'll see you soon in the next video.